Starting, and here is the question. Right, so if you've read and understood, kindly tell me, what are the causes which lead to gallbladder cancer?
Most commonly due to gallstone
Yes,
and maybe due to chronic inflammation,
yes,
chronic prostatitis.
yes. What are the risk factors? What are the other risk factors? Yes,
Might be due to the age, more than 20 years, and
yes,
also the female gender, and
yes,
obesity and smoking,
yes,
and gallbladder polyps more than 1 centimeter.
yes.
Also, maybe due to porcelain gallbladder, and also due to anomaly of the pancreatic biliary junction or choledochal cyst,
Yes,
and cholecyst or gallstone.
very good. Yes. Can you tell me what is the mode of spread of gallbladder cancer?
It can be direct invasion or through the lymphatic.
Okay. How would you grade them?
For the lymph node,
Yes,
can be this involves the cystic lymph node or the pericholedochal lymph node.
yes,
Then it can be to regional lymph nodes such as celiac lymph node and superior mesenteric lymph node, or the
yes,
retropancreatic and suborbital lymph node. Then it can involve the organ lymph node.
yes.
Direct invasion, this is involves the pancreas, the stomach, and the duodenum and the liver.
Very good. Can you tell me the pathogenesis of formation of gallbladder cancer with pseudomembranous colitis, or just the gallbladder cancer? How the pathogenesis?
The gallbladder cancer can either in two forms, can be infiltrating or exophytic mass. Exophytic mass is usually inside the gallbladder associated with the invasion of the underlying wall of the gallbladder. Either both can be infiltrated, appear as ill-defined area associated with the host invasion of the gallbladder.
Yes. So what is the difference between infiltrating and exophytic?
Infiltrating is the most common,
Yes.
while exotic mass, this can be a cauliflower mass.
What is the most common type of gallbladder cancer? The carcinoma.
Adenocarcinoma.
Yes. Which one is the rare? The squamous cell carcinoma. Okay. This patient presented on fourth post-operative day. Squamous cell carcinoma of the gallbladder is there. 5% only. Okay, this patient presented on fourth post-operative day with surgical site infection. Just suppose this patient had sulfur granules, then which organism could that be?
Actinobacillus.
Yes, okay.
Yes.
Can you tell me how would you classify the organisms causing surgical site infection?
It can be either gram-positive or gram-negative.
Yes.
Gram-positive is most common. This is the Staph aureus and Streptococcus.
Yes.
Or can be either Enterobacter.
Yes.
For the gram-negative, can be
Yes.
due to Klebsiella, and
Yes.
Salmonella,
Yes.
and the healthy group Haemophilus
Yes.
and Enterobacter.
Yes. Can you tell me how would you confirm your diagnosis of surgical site infection, or is there a way? Yes.
Firstly, we have the history. We can examine the site of the infection.
Yes.
Then we do maybe do swab for culture and sensitivity. Patient might need blood culture.
Okay, there is one for the indication or for the confirmation or diagnosis of necrotizing fasciitis. There is some scoring system. Can you tell me about that?
This is the low risk indicator for necrotizing fasciitis.
Very good.
The
Yes.
content of 6 parameters. C-reactive protein,
Yes.
more than 100 ounce 50, we can give 4 points, and
Yes.
then there is the glucose more than 10 milligram per liter, is 1 point, and there is hemoglobin. If it's hemoglobin less than 11, this is 2 points. Between 11 and 13.5, give him 1 point. More than 13.5, no point. Then there is the white blood cell. If it's more than 25,
yes,
this is 2 points. Between 15 and 25, is 1 point. Less than 15, I will give him 1 point.
Very good.
Then there is the creatinine level.
Yes, which should be 41. Yes.
Yes.
And then there is glucose greater than 10. That also gives 1 point. Very good. Okay, can you define the term necrotizing fasciitis?
Okay, this is life-threatening condition which affects the cutaneous tissue and the soft tissue.
Yes.
Need high suspicion.
Yes. And this criteria that we have discussed, it is for the laparotomy risk indicator. Okay, can you tell me what is the pathology which is involved in necrotizing fasciitis?
Usually affected the cutaneous tissue.
Yes.
After invading the microarteries due to cutaneous injury.
Yes.
Then it involves the soft tissue with all the facial gland and
yes. This patient, yes.
Okay.
Necrosis and thrombosis of the blood vessels and all that. Okay. How should that patient be managed?
And we manage the patient according to typical surgical patient.
Yes.
And support diagnostic data.
Yes.
Then patient might need immediate surgical exploration in case of fasciitis, and also our debridement of the area, and then swab and culture for sensitivity and give him antibiotics for the
Okay. This patient also presented with pseudomembranous colitis. Can you tell me what that is and what might have caused it?
Pseudomembranous colitis is most commonly affected the colon due to antibiotic use.
Yes.
Which lead to disruption of the colon mucosa due to affecting the normal flora. Then we lead to Mycelium slide overgrowth, which leads to release of introtoxin A and B, and lead to the lead to formation of the exudatus containing inflammatory debris, and which lead to pseudomembranous.
Okay. How does it allow Clostridium difficile to colonize and grow?
After this disruption of the normal flora of the colon,
yes.
leads to overgrowth,
yes,
and leads to release of enterotoxin A and B.
Yes. And eruption of
formation of exudate.
Yes.
Related to the inflammatory debris and white blood cells. This is formation of the membrane.
Very good. What are the some causes of other than pseudomembranous colitis. What are the other few causes of post-operative bloody diarrhea?
Can be either post-operative can be due to stress ulcer or ischemic colitis and infective colitis.
Yes, or bowel ischemia.
Yes.
Very good. Good. Yes, I think this is it. I have. Yes, thank you.
Thank you.
Yes, Dr. Vishek, you tell us. He mixed them, right?
Yeah, of course, ma'am. He really did good, ma'am.
Yes.
Yeah, and everything he told about that was
Yeah,
correct.
he's becoming mature in patho now. He comes prepared. He answers all my questions.
Yeah.
Very good, perfect.
I'm still learning.
No, but this is good learning. It's progress.
Yeah.
That's how we will make Dr. Fatumat as well. Yes, please. Dr.
Dr.
Abhishek,
Muhammad,
if you
I have a
can.
question.
Yes, please.
Yeah, for Dr. Muhammad, like
Yes,
if
please.
without the RENEC scoring, like you have said about the scoring, what are the clinical signs you will look for?
For necrotizing fasciitis,
Yeah.
there's maybe them black margins. I will look black margin around the wound.
Yes.
This is the indicator of the necrotizing fasciitis. Maybe there's erythema, and
Okay.
I think there is
Erythema for
no.
cellulitis. Yeah. Another one.
Yes.
Crepitus. There will be crepitus, and like it will not first involve the skin, so we must need like high index of suspicion. Under suspicion, we will go the exploratory diagnosis by making a keyhole incision and insert our finger through that keyhole.
Yes. Yes.
If the tissue separates along the fascial plane, so that gives us like it's the most possible one for necrotizing fasciitis. We have to go for extensive wound debridement and surgical dressing, everything.
But if you express the wound, there will be no pus discharging. Most likely.
Sorry?
For the, yes.
Sorry. What did you just say?
If we express the wound of the infected area,
Yeah.
no discharge will be come right for
Yes, no
necrotizing.
discharge will come. Yes, no discharge will come. And for pseudomembranous colitis, there is a characteristic line, exudative fibrin deposition. Just don't miss it. Along the intestinal wall, there will be exudative fibrin deposition.
Yes.
Okay. Yeah.
Thank you.
Right. Good. Yes. Anyone else want to give feedback? Anyone else want to say anything? Discuss? Comment?
Dr. Mohammed, ma'am,
Yes,
I have
please.
one question.
Yes.
Could you tell me what is the colonoscopy? What would you find if you do colonoscopy of a patient with pseudomembranous colitis?
Good.
There will be yellow coloration of the
Yes.
pseudomembranous with exudate, as the project said. This exudate confirming of inflammatory debris.
Very good.
White blood cells.
White blood cells. Very good.
Okay. Yes.
Good. Now he's preparing in
Thank you.
pathology station very well.
Thank you.
That's the kind of effort I wanted. Very well. Very good. Excellent. Really happy. Okay, Dr. Muhammad Ilyan, are you here? Should we move on? History taking? Can anyone help Dr. Muhammad? Maybe Dr. Kumar or someone? Very good. Yes. Dr. Muhammad Ilyan, are you here? Is he here? I saw him being added. He left or disconnected. He got disconnected. All right, then we will end. Maybe he'll do it tomorrow.